All right. Well, good morning. Good morning, everyone. Welcome to our community conversations, our Tuesday edition, as we continue this work uh, through the Rhode Island Ministers Alliance, along with our partners, as we advance our health and healing initiative to make sure that we provide information, knowledge, access um, to the Rhode Island Black and Brown, Indigenous people of color community on the what we say knowledge is power, right? About getting screenings, the opportunities to talk to your doctors, to find out about um, cancers that are screenable and curable, to encourage so many people to get screened, get checked. Is vitally important. And so we're going to turn over our today's conversation to our wonderful leader in chief, Reverend Howard M. Jenkins, who is the president of the Ministers Alliance. Thank you, Pastor Jenkins, for all that you're doing to lead this agency, this group of people, but also for your leadership in the Ministers Alliance. We do want to make sure that we emphasize you going to see your doctor, uh, pap smears, breast mammograms, colonoscopy, you know, very easy things that you can get done regularly. Don't forget to talk to your doctor. Don't just see them when you're sick. Make it a point to get regular checkups because early detection is the first stage to curing. All right, Pastor Jenkins, you're on deck.
Thank you so very much, Pastor Lori Smalls, and thank you all for all that you do. You took away all my thunder, all my thunder. So
Not the thunder.
I'm gonna have to navigate through the woods now. But as we have been doing for over 2 months now, we have been intentional in regards to educating and encouraging our communities, our Black and Brown communities, in regards to the education on cancer. We are focusing on 4 specific cancers, which is cervical, breast, colorectal, and lung. But we also recognize there are other cancers out there that are concerns within our respective communities, and in regards to men, which one is prostate cancer. So we've added that as an addition. But the most important thing we want to do, and taking the words from Pastor Lori Smalls, is screening, screening, screening. But what we want to make sure, if there's no other message that gets across, it's important we recognize that screening is extremely important. Early detection. One of the things that we've identified, that cancer is not a death sentence. And so we must be able to talk about it. And that becomes extremely important in regards to what is going on within our families and within our extended families. So it becomes a very, very important that this particular initiative that we are embarking upon, that you are able to not just listen to what is going on, but also share what you are hearing with family and with friends. And that becomes extremely important. As we begin to navigate through this particular initiative, we are quickly approaching the aspect of screening. But what we have been done with some intentionality, we want to make sure that these community conversations that we are having are impactful. And so one of the things that we are intentional in doing as we approach the screening aspect of cancer, these community conversations will continue to go forward. And so what we like to make sure is that we recognize that we have a passion for understanding and recognize the importance of cancer, but we don't have the knowledge. And so we have been intentionally making sure that we have subject matter experts, that we have doctors, that we have persons that understand the various aspects of cancer. And so that is what amplifies the community conversations. And so it also gives insight relative to the importance of screening and being able to be screened, and in addition to that, for survivorship support. And so there's a 3-pronged approach that we have in regards to the cancer initiative and increasing the awareness. One, community conversations that we've been embarking upon. 2, cancer screening, which is fast and approachable. We'll talk more in detail and in depth about that. And three, survivorship support. And that becomes extremely important. But we've also expanded survivorship support to also add caregivers because we began to understand as we've navigated through these community conversations, there are a number of caregivers that are impacted, and being able to help the survivors and the caregivers becomes extremely important. The purpose of the survivor support aspect of it is to support the survivors, but we also recognize that it's a toll on families, a toll on friends, it's a toll on loved ones. And so what we also like to do is be able to share their particular stories and the hurdles that they go through in regards to what we're trying to do. The reason why we've been extremely successful with these particular community conversations is because we have been intentionally having partners that also have that same passion in regards to cancer prevention. And so that becomes a help for us in regards to being able to ask persons to help us in regards to the explanation of the various cancers that are also that people are dealing with. But just as important, we have also been able to bring on board community health workers. As this particular program gains traction, we have brought on one additional community health worker, Misty, which will be helping us. You'll be seeing her quite a bit. She's actually on the screen today. You'll be seeing her quite a bit. And so that is a message for us as we begin uh, to journey down this path of cancer. We cannot do it alone. And this initiative has pretty much given us the understanding that this is much bigger than us, and we need as many subject matter experts as we can. And so that becomes extremely important in regards to what we need to do. All the voices that we are hearing from the community conversations are important, and we need to hear more voices. We need to be able to hear the persons that are understanding the benefits of cancer screening, the understanding of educating in regards to cancer, the understanding of encouraging our community participants in regards to cancer. And so that becomes our responsibility in recognizing that all that we can do is extremely important. And as you have watched us throughout these last 2.5 months, not only have we been able to have these community conversations via Facebook, via Zoom, but also just as important, we are intentional in having these face-to-face, in-person type conversations as well. And so what we also like to do is make sure that we encourage you, if you have an organization that would like to host any of these particular events, please feel free to let us know. Go on our website, Ministers Alliance Rhode Island website, so that you can identify your interests and so that we can be able to help you to help our community. And that becomes extremely important. And so what we want to make sure we're able to do is to identify those persons that those persons and organizations that can help us get the word out. And so what Pastor Pam, do we have our subject matter expert with us this morning in regards to cancer?
Yes, Dr. Jansen.
Dr. Jensen, welcome to our community conversations. And I ask if you can share your expertise with us at this time.
Hi, yes, so I am a second-year GYN oncology fellow, and sorry, I'm just outside, but because the weather's so nice today. And I take care of patients with gynecologic cancers, so cancers of the uterus, cervix, ovaries, vulva, and vagina. But I think the subject of today was for screening. So just briefly, I'd like to go over, so screening tests for anyone who is female or identifies as a woman would include mammograms. Depending on which guidelines you would look at, it's usually recommended to start at the age of 40 or 10 years prior to the earliest cancer diagnosis in your family. So for example, if you had an aunt who was diagnosed with breast cancer at 45, you might need to start doing your mammograms really early, like 35. And then for the other screening tests, I like to talk about pap smears. So pap smears have become kind of complicated. It used to be that you would just needed to get one every single year. But now there's a couple new set of guidelines that they've actually made. And they the new guidelines are kind of based on your age and then also based on your previous testing. But the best thing you can do is just make sure you have a recent conversation with your OBGYN about when you were due for a pap smear, when you should come back in. And the other thing to remember is that a pelvic exam is different than what a pap smear is. But you need to undergo a pelvic exam in order to have a pap smear. But that doesn't necessarily mean every time you've ever had a pelvic exam, you've had a pap smear. And so sometimes that distinction is not well known for some patients. Pap smears are for cervical cancer. Most of cervical cancer comes from the HPV virus, which Gardasil is the vaccine that prevents that. And it's one of the only vaccines that we have out there that prevents cancer. So that's recommended up to the age of 45. So if you're under the age of 45 and you don't think you've had the Gardasil vaccine, that's also something that would be good to talk to your primary care provider or OBGYN about, because it reduces your risk of both cancer and genital warts. And then I also like to talk about colonoscopies. So the age for everyone is 45 is when you should start getting a colonoscopy, or there's another test called a Cologuard. That's where you can submit a stool sample and they can run a DNA test on it as well as test it for blood. The stool sample test is not as good as a colonoscopy, as you can probably guess. And you have to do that about every 3 to 5 years, whereas a colonoscopy you can do about every 10 years if it comes back normal. The age of colon cancer is going down, unfortunately, though. So if you develop any of the following symptoms like bleeding, changes in your bowel habits, that's something you should talk to your primary care provider about and get a referral for a colonoscopy. If you find out that anyone in your family has had an early diagnosis of colon cancer as well, that's another reason to start colonoscopies earlier. So if you were, like, let's say you had a family member who had colon cancer at 48, you would need to be considering getting colonoscopies at 38. So those tend to be the big things I like to talk about.
So, Dr. Jensen, you said something that, are most people aware of these changes in regards to pap smears, that being widely communicated? Because you say there's a lot of changes from what has been done in the past.
They're not being well communicated, to be honest, and that's something that is one of my active projects of research. Is I'm trying to develop a patient education tool that's available online about pap smear guidelines. But currently, if you go on like the CDC website, or another good resource is called ACOG, the American College of Obstetrics and Gynecology, and they have patient information that is written in a level of reading level that is typically accessible for most people, explaining those guidelines. But to try to summarize it, basically, you should start getting pap smears at the age of 21. And then, unless you have HIV, and if you have HIV, then you really should be starting to get them 1 year after sexual debut or first sexual contact. And then 21 to 29, you should be getting them every 3 years. And then 30 to 65, you should be getting them every 3 to 5 years, depending on if you get HPV testing with your pap smear, which is an additional test that your provider can order. And then after 65, they're not recommended if you've always had normal testing, but a lot of women haven't always had normal testing. So I usually advise people to really talk to their OBGYN about like what their history has been on their pap smears. And if you've had abnormal pap smears in the past, then you should probably continue to get them, because there's a chance that you could still develop cervical cancer even into your 60s and 70s. Cervical cancer is treatable and curable as long as it's caught in an early stage. But the only way you can catch it in the early stages is by pap smears or exams. I think a lot of people think with cancer that you're going to have symptoms with all of these types of cancers. And the reality is, unfortunately, until they're advanced and incurable, most of the time you will not have any symptoms. And so that's why there's all these screening tests recommended, is that we're trying to catch these cancers at a stage that they're completely curable, either by surgery or chemotherapy or radiation, to allow you to live a long and healthy life.
So a number of the persons that may be listening right now may not have a primary care physician. So if they go into a clinic or even an urgent care, can they get a pap smear at that time or be scheduled for a pap smear?
So the hard thing is, so most urgent care or like emergency places will not order screening tests because they don't have a way of following up with you, and a lot of those providers don't have clinics. So like an emergency medicine physician doesn't have a clinic. And so they can't schedule a visit with you to talk to you about those results. I know that there's a dearth of primary care providers in Rhode Island and Massachusetts these days, and that's a complicated issue that has to do with reimbursement, burnout, the pandemic, all of those things. But one route that you can go is you could seek out like a mid-level provider, like a nurse practitioner or a PA who is doing primary care provision, and they can also order those tests, and they would have a clinic that they can follow those results up with you. And then OBGYNs in general, I think, are not too over impacted. And if you are female, most OBGYNs will order your mammograms. They will obviously do your pap smear for you. And then sometimes they will also order your colonoscopy for you if you really can't get in to see a primary care provider in a timely fashion. I don't know whether this is true, but I would hope that some primary care providers would also put in the orders for you, even if they haven't seen you yet, but some may not be comfortable with that.
Because you brought up some very interesting points that, most people are not aware of. So is there general information that is being published that could be used as handouts so that we could actually educate our community?
I think, let me double check. I just have my computer in front of me. Some good websites, resources for screening guidelines. You can start with the CDC. And then, yeah, they have a handout here. And then for the other governing body that for screening tests that exists is the USPTF, or the United States Preventative Services Task Force. And so they have, let's see what's accessible for that. Yeah, they have guides that they've also released in Spanish and English on a lot of subjects, it looks like. Including things like lipid levels, HIV testing, and breast cancer screening.
Dr. Jansen.
Yeah.
I had a question. So you said that pap smears and pelvic exams are not the same. I'm familiar with pap smear, but what's the difference with the pelvic exam? Is that external versus internal?
So a pelvic exam, by my definition, by a definition of OBGYN, would be an examination of the vulva, an examination of the vagina, the cervix, and then what's called a bimanual exam, or the exam where the practitioner inserts fingers into the vagina and a hand on the abdomen to examine the shape of the uterus and the ovaries. That is just an exam. A pap smear is actually a pathology test where your provider during the test, when they place the speculum during the exam, takes a brush and brushes the surface of your cervix to collect cervical cells. And then that gets sent to a pathologist to read, and then they decide if those cells look normal or abnormal. So a pap smear is actually is a pathology test, but a pelvic exam is what is being done during the visit. Now, you can undergo a pelvic exam in the emergency room, in any office that you go in for women's health, but that doesn't necessarily mean your provider did a pap smear. And I think that is what's hard for people to understand, is because it used to be that when pap smears were required every year, they always happened every time you went in for your yearly annual. But now we've somewhat made it more complicated because we're trying to reduce the amount of testing that we're doing, because we realized we were over testing people, putting people through too many biopsies, putting people through too many procedures, because sometimes these pre-cancer lesions that we were picking up on the cervix regress and go back to normal, particularly in young women. Now, as we get older, those are much less likely to regress and are more likely to become cancer in the future. But that distinction is kind of subtle, and I think it's hard for people to separate in their minds that they don't always get a pap smear every time they have an examination of their vulva, vagina, and cervix.
Thank you. I did not know that, and I will certainly share that information with others. I also wanted to let you know, I'm looking at Rhode Island Department of Health, and if you go on there and you put in cancer screening, there are different resources there for people as well. I work for the Rhode Island Department of Health, so I was just when Reverend Jenkins was talking about clinics and that, I thought I would take a look because the cancer program is right next to me. So we do have some women's cancer screening programs. We have some information for providers, colorectal cancer, skin cancer, all different types of cancer screenings, breast cancer, cervical cancer, just for a resource for others as well. Thank you.
Oh, yeah, and I just looked up it up too. It looks great. This looks like a great resource for patients.
Thank you, doctor. I'm like with Sister Tanya. I'm 60, so learning these things about screenings is like eye-opening, and it's so important, and especially the HPV information that you provided as we're thinking about our young people, as some of them may be, exiting our home, going to college or going on their own. It's so important to be able to pass that information on, that there is such a preventative tool for cancer. And my mom she had cervical cancer. She wasn't diagnosed until she was 75. So this thing about going to see your doctor regularly, so important. Thank you so much for sharing that with us.
Yeah, and I think also to your point is, I think a lot of people after they stop having children think that they no longer need to see an OBGYN or have a pelvic exam. And I would recommend still trying to go every couple years to have a pelvic exam and considering a pap smear. And because things happen and your primary care provider may not be well trained enough to provide an adequate pelvic exam. So I really encourage women or patients with female parts to keep a relationship with an OBGYN through their whole life. Doesn't mean you need to go every year, but every other year would be reasonable, because there's still risks for things like vulvar cancer and vaginal cancer and ovary cancer. The other thing I also like to educate people about is the risk of uterine cancer. So uterine cancer, there is no screening test, but the thing that most people get diagnosed with is, or how they get diagnosed is that they present with postmenopausal bleeding. So I think it's really important for patients to know if they develop bleeding after menopause, they need to go in to see an OBGYN to either get an ultrasound or a biopsy, because there's a risk that is uterine cancer. Now, postmenopausal bleeding could also be things like bladder cancer, rectal cancer. So it's important to get in to see a doctor for this complaint at always. A lot of people ask me why there isn't a screening for uterine cancer, and the reason is that the bleeding is usually an early onset symptom. So we usually catch it in stage 1. About 80% of endometrial cancer cases are caught in stage 1. And also the test for endometrial cancer is an endometrial biopsy, which means we sample the inside of the uterus, and it's pretty uncomfortable, like even worse than a pap smear or a pelvic exam. So we don't want to put every single person through that type of biopsy, but only do it as needed for the complaint of bleeding.
So I say, doctor, often we as women avoid those regular exams because there's nothing pretty about it. But do you have any recommendations for women who may have fibroids? Because oftentimes, Black and Brown communities, we have fibroids that present during our childbearing age.
So fibroids in of themselves are a benign, they're not a cancer. They're tumors that arise from the muscle of the uterus. So I usually explain to everyone the uterus has a outer lining, an inner muscle layer that that contracts and gives birth and causes cramps. And then the lining of the uterus within, the endometrial lining, is what gives us menses and supports a pregnancy. But the fibroids come from that muscle layer. And we don't know why, but we think roughly like on average, 60 to 70% of women have them. And it's higher, like you said, in African American communities, up to 80% of African American women will have fibroids. They can grow quite large and make you very uncomfortable. Like I've taken out fibroids as big as a 7-month pregnancy. So I think if you have symptoms and you're uncomfortable, there's a few ways they can be managed. They can be embolized, they can be removed surgically, either through what's called a myomectomy or a hysterectomy. If you want to retain your fertility, you can consider removal of just the fibroids. That's a myomectomy. But that is a much higher blood loss surgery than just a hysterectomy for fibroids. There is some thought that after menopause, they will get smaller, but even so, because they're responsive to hormones, and when you go into menopause, your hormone levels drop. But even so, people may still be symptomatic from them. There is a rare risk of a cancer that can arise within fibroids. That's called a sarcoma. But it's pretty rare. Like we don't see a lot of those cases. But if you notice that your fibroids are growing quite quickly, it's very reasonable to see your doctor and ask for an imaging study to see if they've changed and gotten bigger.
Thank you. This is a difficult conversation, but it's necessary because oftentimes I think our misconceptions about fibroids and what they mean to us and having these surgeries. And I know that we don't like to talk about hysterectomies. But after my mother was diagnosed, this is my story, she recommended to her children who were no longer having, children, if you have fibroids, have a hysterectomy, right? And I don't know if that's a necessary leap, but, we associate our history with being diagnosed with cancer based on our experience. And so I certainly do appreciate the Ministers Alliance for giving us the platform to be able to dispel some of these things so that our people can, have these wonderful conversations with their doctors.
Yeah. And I think I've definitely talked to patients who, are hesitant to have a hysterectomy either due to the surgical risk or because of perceived loss of identity as a female or a woman. I think both are completely valid concerns. But I think if fibroids are impacting your life to the point that you're missing work, you're missing out on life, you're uncomfortable all the time, it wouldn't be unreasonable to consider surgical management.
I have a question as well. If you have a partial hysterectomy, or any hysterectomy at that point, is it still to go and get checked, like the pap smears often, or?
That's a good question. So partial hysterectomy typically refers to someone who only had the top part of their uterus removed and that they still retain their cervix. If you still have a cervix, you should still be going in to get pap smears because you could still develop cervical cancer. And we do see those patients pretty frequently in our office who stopped kind of going to the doctor because they had this partial hysterectomy, stopped getting care. And then they then have a cervical cancer, even though they, you know, in their mind, they no longer had a um, any gynecologic problems. You also want to be sure whether you have a hysterectomy, whether you retained your ovaries or not. Most people who have hysterectomy prior to menopause will retain their ovaries. And so you just need to be cognizant of the fact that there is this risk of ovarian cancer later in life if you retain your ovaries. And then, you know, if you don't retain your ovaries, you have no tubes, no cervix, no uterus, then yes, you probably could consider stop going to an OBGYN. But again, you still have a vulva and you still have a vagina. So I would still recommend seeing an OBGYN at least every couple years, just so that they can inspect that area even into, you know, your older ages.
And we did have a question about PCOS. We see a lot of young people or who are experiencing that disorder or that situation. Can you address or answer any questions? Are there any additional cancer risks associated with PCOS?
So the big risk with PCOS is I kind of think of PCOS as kind of like a metabolic syndrome, an endocrine syndrome, because what you're seeing is that the ovary is not ovulating normally. And so people get these really long periods where they don't menstruate. And then when they do menstruate, it's really heavy. They have infertility because they're not ovulating on a regular basis. And so they can't conceive. And then they have an increased risk of conditions like diabetes because it comes with an insulin resistance. And then in terms of cancer risk, the only cancer risk I really think about would be endometrial cancer risk. And so that's more related to excess weight. So we do know that when you have so to kind of back it up, and this might be like too much detail, but if your fat tissue in your body produces estrogen. And so, yeah, which can be good for you kind of going into menopause because then you have an excess use of estrogen, but estrogen stimulates the inside lining of your uterus to grow. And if that is overgrowing, you get heavier periods. And then you also have an increased risk of uterine cancer. So unfortunately, we are seeing uterine cancer on the rise in the US. We think it's related to the trend of increase in obesity rates, but there may be something else going on that we don't know about. We do think it correlates, and we do know that having excess fat tissue is like an independent risk factor for uterine cancer. So that's usually that's the only cancer risk I think about with PCOS. PCOS, I think more about like infertility and that diabetes risk and cardiovascular risk. So if someone does get diagnosed with PCOS at a younger age, you know, you want to think about like lifestyle management. Are they getting activity in? And it's not just weight loss that we're talking about. It's also like, are you an active lifestyle? How is your diet? And a lot of people with PCOS that I know really swear by like dietary management, but like I can't recommend one diet over the other necessarily because there's not a ton of data on that. But finding a good OBGYN, and then you could consider getting like a dietitian. And then if you are seeking fertility, that can also be, you can be referred for that. The other thing that sometimes people need with PCOS who are trying to achieve fertility is ovulation induction. I don't know if any of you are familiar with that. And so that's where you can take a medication to induce ovulation. And that usually helps people with PCOS who are trying to become pregnant because the problem is ovulation.
Doctor, you have provided a
Sorry,
wealth
that's
of
maybe too much
no,
information.
it's not.
No, thank you.
Very helpful.
Yeah, I was
Yeah.
going to say thank you so much because I hear this diagnosis so much lately in young women of color, and I just wanted to know if there was any correlation with cancer. I knew about the infertility, but you gave me some additional information to share as well. Thank you.
Yeah. Yeah, and one thing I also like to address with uterine cancer is unfortunately in African American patients, there's a higher rate of the more aggressive types of uterine cancer, and they tend to present at later stages. I think if we think about like why that's happening, it's probably related to the structural problems of racism in medicine and also access to care. Because if you don't have a good access to care, then it's probably going to take you a long time to get in to see a doctor, and you're more likely to be in an advanced stage by the time you get diagnosed, which obviously is a huge inequity in medical care in the United States. But it's that, I mean, in my wheelhouse, those are the things I take care of.
So that's a really great segue to Ms. Panita Pivale, who's from United Healthcare. We've been emphasizing, please do not let lack of access to insurance be a reason why you don't go to see your doctor. And so, Panita, can you just address some of the services that your agency offers, please? And thank you.
Yeah, so if someone has health insurance through United Healthcare or any other MCO, if they do not know where to get services, everyone has a member services number. On the back of your card, there's a 1-800 number. If you do not know where to utilize services, you can call that 1-800 number to see where you can go. You know, through United Healthcare, I'm on the Medicaid side. You know, that is a covered benefit through our health plan. But I remember there was some information, and luckily I was a women's cancer screening outreach worker for many years. I worked for the Department of Health, and I did community outreach. So, you know, we had talked about lack of services to care, right? And that shouldn't be a barrier to receive services. And I wanted to emphasize that because, you know, many years I had spent outreaching to those that did not have health insurance, or if they were underinsured, they would be able to seek services. And I know you put the information in the chat, but if I may, and I'm gonna do my best. I was trying to share my screen, but I lost connection earlier. So let's see. Ooh. I don't know if this is gonna work, and I apologize if it doesn't work. But can you see my screen?
It started for a while, then it went back to your beautiful face.
Oh, okay. I'll go back to my.
No, we lost her altogether.
I think we lost her. She'll jump back on.
I did that. Here she comes.
Can you hear me?
We can hear you.
Yes.
Sorry. I'm trying to do my phone is like, I try to do it with my computer, and I've been having, I don't know what's going on, but I'm having difficulty today. But I was trying to share the Women's Cancer Screening webpage, and I can't do it right now. But through the
From
Women's
Rido? Is it from Rido?
Yeah, it was on the
Okay,
webpage.
let me see if I can get it.
Yep. So let me try to put it in the chat also. Here you go. Then I can sort of talk through it. Just love technology.
It always is very helpful. But it reminds us that we're doing this wonderful work to make sure that we can address as many people as possible. So
yeah, I put it in the
appreciate
chat. If you can open that up, I can sort of walk through it, but it shouldn't be a barrier to care, right? So through the Women's Cancer Screening Program, if you are uninsured or underinsured, regardless of documentation, meaning if someone is not 5 years legally present, they are able to seek services through the Women's Cancer Screening Program. And if you can scroll up, it talks about, there you go. So it talks about eligibility. You know, you just have to be a resident of Rhode Island, making income of 250% of poverty level, or below, less than 250% of FPL, but it covers, your basic health screening. So your cervical cancer screening, your breast cancer screening, diagnostic breast cancer screening, meaning like a mammography as well. So it does cover, so these are the ages that she had pulled up: 21 to 29, 30 to 39, what you can receive, 40 to 64, and 65 and up are not eligible unless they are without, um, insurance or Medicaid eligible for all the other services. So I've, walked many people through the women's cancer screening program, and we were able to save many lives. Individuals that had a breast lump or something that, was found through the women's cancer screening program. So please don't let that be a deterrent. Like if you don't have health insurance or you're underinsured, meaning like if your insurance, if you have a high deductible, that's underinsured, right? Or if your insurance covers catastrophic, events or things like that, that it doesn't cover screening services, you're able to obtain screening, so that is not a deterrent. So we did put that in the chat for folks to see. But if you do have health insurance and you don't know where to go, please check on the back of your card. Like I said, there's a 1-800 number that you can call to see, where you can go. If you have United Health, feel free. I'll put it in the chat after to reach out to me. We can walk you through where you can go and get services. But it should not be a barrier to care. There are services out there. It's just a lot of people do not know where to go. And that's why we're having these community conversations. Like we said, knowledge is power. And so you take this information, you pass it along, you share this information. It's a wealth of information that we're sharing together. And every time I come on, I'm always learning something different. I'm not know all, be all, so I'm always learning as well myself. I have, family members who have had breast, cervical cancer, colon cancer, various cancers. Been on the other flip side of, walking my loved one through the process as well. So as I always say when I come on, you know your body best. If you do get a cancer diagnosis, it doesn't mean a death sentence, although very scary. And sometimes very scary to get sometimes, services. Like I went with one of my best friends who had a colonoscopy for the very first time, and he was scared to death to go. So I said, you know what, I'm going to go with you. I'm going to be that person. I'm going to hold your hand, check on you, make sure you go, get the services, and got a clean bill of health after. So he's good to go for another few years. So don't let that be a deterrent. And if you do get a cancer diagnosis, it's not a death sentence. It is early detection is always key. Early detection is what we always talk about, and have that conversation with your family and your loved ones. And I'll end there. I said a mouthful.
And we have Tanya Gilbert on, and there's a very big initiative that she's pushing in regards to cancer. And Tanya, can you speak on what you're sharing within the community as well?
Sure. So it's a pleasure to join this conversation with you all, and I plan to join more along with my colleague Renee Amasori from Oasis International. And we are, I just started working at the Rhode Island Department of Health early April in the tobacco control program. And what we're trying to do in the tobacco control program is just help and be available to people as they pursue healthier lifestyles. Specifically, I am managing a grant that is for menthol and health disparities in menthol, meaning big tobacco companies have been targeting certain populations, and we're trying to reach the populations that big tobacco targets, such as the BIPOC community, LGBTQ plus community, women, especially our Black males. And we know that with tobacco use, especially with the menthol helps to numb the throat and disguise the taste of tobacco, and it makes it easier to use tobacco or nicotine products and harder to quit. And so we want to be there to offer people and their loved ones and friends the opportunity to quit, so providing quit resources for people as well. And as Reverend Jenkins was saying, we have a work group that meets the last Tuesday of every month that we're looking to diversify. I'm trying to get more community organizations, diverse community members, because the grant is specifically for African immigrants and Black Americans. I really want to diversify who is on that work group. And we have other things that we're trying to do in my department. We have a person that focuses on cessation, others on policy. You may know that the governor just signed his budget, and in the budget, he included additional funds for enforcement of tobacco stores that are selling flavors, and they adjusted some words for a flavor ban. And so we need help even going to the hearings and just saying, we want a flavor ban, or this is detrimental to our youth. So there's lots of things that we can do, and not just have things done to us, but we can be present to advocate for ourselves and our community and our loved ones.
And thank you very much, Tanya. What is happening as we have opened these community conversations regarding cancer? Persons have come to us in regards to, do you know this is going on? And so what we like to make sure that we're able to do is also create open dialogue, because there's a lot of things within our communities that we're just not aware of. And we know that we have persons that are smokers. We know that we have all these different flavored types of nicotines that are out there. And we know vaping is something that is running rampant within our particular communities. And so whatever we can do to highlight other types of potential cancers, we like to bring that to the forefront as well. And so you'll be hearing more from Tanya as well, just as we have brought on Dr. Jansen in regards to the various cancers that are with her expertise. We want to make sure that we also have the ability to diversify in regards to educating our communities and our listeners in regards to the impacts of cancer and how we can prevent these cancers, and how we can also recognize some of the things we need to stay away from as potential risk in regards to healthy living. I think this was an excellent community conversation that we've had. I want to thank Dr. Jensen for sharing, and we will be inviting you back, Dr. Jensen, so just keep your calendar open. And so there are some things that, that I've learned. I understood pap smear, just listen to my mom, but there's a lot more to it than just that. My wife always says that that it must be a male doctor that invented all these types of tests, because if it was a female doctor, they wouldn't be so invasive or so painful. So Dr. Jansen, I'm glad that you're on top of this. So maybe somewhere down the road in the near future, all these tests that women are taking, I understand they will be invasive, but something can be done to make them a little more I only had a word for it. But you know what I'm saying. I'm just saying what I'm saying. You know what I'm saying. But thank you so very, very much for sharing. And we definitely appreciate all that you're doing. Panetta, we thank you as always for being a great partner in regards to what we're doing, the initiative of United Healthcare. We greatly appreciate all that you all bring to the table. And Tanya, welcome on board. Please continue to join us so that we can help educate our communities and our young people in regards to what is going on in regards to the world of nicotine. Are there any closing remarks from Dr. Jansen that you'd like to share?
I wish the tests were better, and I know that they're hard to get. And I think in terms of pap smears, there's a lot of work being done to see if we could just do like swabs of the vagina and test for HPV. And those studies are ongoing, and those might be easier for people to obtain and handle as opposed to a full-on pelvic exam. But I encourage people to think of these tests as investments in their future selves. And I think as the old phrase goes, an ounce of prevention is worth a pound of cure, and there's no disease process that's more true for than cancer.
My wife just told me that my daughter has been diagnosed with PCOS, and one of the things that we were wondering is this, Dr. Jansen, due to taking birth control pills?
No, birth control pills are actually one of the treatments for PCOS that we often will place patients on. We think that the PCOS is somewhat related to the rising weight gain, but again, we're not 100% sure. Part of it may be that more people are getting diagnosed because we're more aware of the diagnosis now. But birth control pills do not cause PCOS. They actually seem to help regulate people's hormones back to a more like the natural cycle of the female hormone cycle.
It's interesting because my daughter and her friends, believe it or not, around the age of 18, 19, a number of them were diagnosed with this at the same time. So, I was trying to find out what the common thread was with this, with PCOS.
Yeah, I mean, I think we don't know like exactly what causes it, but we do know that lifestyle changes, dietary changes seem to help, and birth control pills seem to help. There are a couple like hormonal treatments that we use sometimes, like spironolactone, for example, for some people have hair growth that they have to deal with, or acne. But I think if you are worried about that diagnosis, I really encourage meeting with an OBGYN, and sometimes they will even refer you to a reproductive endocrinologist for further workup. But in of itself, the main conditions I worry about are, like I said, is like infertility and diabetes from the result of a PCOS diagnosis.
Yeah, so my daughter has been going to whatever you guys go to for a number of years. So I don't know what I'm saying. I'm just saying what I'm saying. So y'all just bear with me. But
no, it's good. It's good.
You know what? I give you a lot of credit, Pastor, because you're the only guy on here. So like, we're not gonna take it. We're not gonna be too hard on you. Go ahead.
All right. Well, thank you for having me, and I hope everyone has a great day.
Yeah, thank you all very much. Thank you, Misty. Thank you, Panetta. Thank you, Tanya. Thank you, and always thank you, Pastor.
So
Pastor
good. It was a good one.
Bye, everyone. Have a great day.
Bye. Have a great one.
Bye,
Thank you.
everyone.
Thank you.
Bye.
Bye. Thank you. Thank you.